Welcome to today's Explainer. I'm really thrilled you're tuning in because today we are tackling a seriously high-stakes, highly precise clinical journey, urinary catheterization. Now, I know what you might be thinking. It's just putting a tube in a patient, right? Actually, scratch that. It is way more than that. It's a critical intervention requiring absolute mastery of anatomy, technique, and of course, infection control. Whether you're in a busy hospital, an outpatient clinic, or out doing home care, nailing this procedure makes literally all the difference in the world for your patients. Right out of the gate, we gotta address the absolute core paradox of this whole thing. Think about it for a second. The urinary tract, it's normally a completely sterile environment. By bypassing the body's natural defenses, like the natural flushing mechanism of voiding, to insert a catheter, we are basically leaving the front door wide open for microorganisms. We run the massive risk of introducing catheter-associated urinary tract infections, and if bacteria hitch a ride straight up those ureters to the kidneys, bad news. Because of this, meticulous stale technique isn't just some nice-to-have recommendation. It is absolutely our highest priority. Okay, let's take a quick look at our roadmap for today. We're going to cover 1. The basics, 2. Indications and contraindications, 3. Catheter types and supplies, 4. The insertion procedure, and finally, 5. Safe catheter removal. Let's jump right in. Starting off with Section 1, the basics of catheterization. So, fundamentally, what are we doing here? We are carefully threading a thin, flexible tube right through the urethra directly into the bladder. It acts as our frontline lifeline for patients who just cannot void independently right now. Maybe they're post-op, critically ill, or dealing with severe trauma. At the end of the day, it's all about safely managing urinary function when the normal flow is blocked, or when we absolutely need hyper-accurate output measurements.
Moving right along to Section 2, Indications and Contraindications.
All right, let's talk about the rules of engagement here. On one hand, we've got our clinical green lights, our indications. If your patient is stuck dealing with acute urinary retention and simply can't empty their bladder, we obviously have to step in. Same goes for critically ill ICU patients where monitoring every single drop of output is vital, or when we desperately need a perfectly sterile urine sample. But hold on, we absolutely have to look at the red lights too. We must constantly weigh those vital indications against severe contraindications. If a patient has known bladder carcinoma, recent urethral surgery, or they're on heavy anticoagulation treatment, well, inserting a catheter could cause massive catastrophic trauma. You always have to step back and look at the whole clinical picture. Next up, Section 3, Catheter Types and Supplies. Now, as you probably know, not all catheters are created equal. They mainly vary by the number of lumens, or internal channels, they have. A single lumen, or straight catheter, is basically your quick in and out tool for short-term needs or just grabbing that sterile sample. Then you have double lumen catheters. These guys are built to stay in place. Fun little fact for you, these are often called Foley catheters, named after Frederick Foley, the surgeon who first designed the anchor balloon mechanism way back in the 1930s. So one channel drains the urine, and the second lets you inflate that anchor balloon. And finally, the triple lumen catheters. These are the heavy-duty options, used a lot post-operatively, allowing you to run a continuous stream of bladder irrigation to clear out blood clots and debris. So, what's the crucial number to burn into your brain for your clinical exams regarding male patients? It's this specific sizing range right here, 12 to 16 French. Sizing is absolutely key to respecting individual anatomical considerations. We want to prevent trauma while still making sure we get completely adequate drainage. Contrast that with female anatomy, which generally requires a slightly smaller size, usually ranging from 10 to 14 French. Having the exact right sterile catheter on hand, along with all your other supplies like sterile gloves, antiseptic, and water-based lubricant, it really just sets the entire stage for a safe procedure. Even if you're, desperately trying to perfectly maintain a sterile field at 3 a.m. during an absolutely chaotic shift. Which brings us to the main event, Section 4, the insertion procedure. Take a look at the stark contrast in our measurements here. Because the male urethra is significantly longer and honestly much more convoluted, you're going to need a generous 6 to 7 inches of lubricant, and you'll have a much deeper insertion depth, about 7 to 9 inches. Now for females, the urethra is much shorter and more direct, so you're only looking at 1 to 2 inches of lubricant and about a 2 to 3 inch advancement to safely reach the bladder. Keep in mind, these aren't just arbitrary numbers, they are precise anatomical maps you absolutely need to follow. Now, regardless of the patient's sex, our baseline prep follows these exact same, very strict steps. First up, always explain the procedure to bring their anxiety down. Then, get them positioned optimally, supine, knees bent, thighs rotated outward for female patients, or legs just gently separated for males.
I really want to emphasize step 3 and step 5 here. Meticulous hand hygiene and donning those sterile gloves are your ultimate shield against pathogen invasion. And selective draping, that is not just about keeping your sterile field intact, it is absolutely vital for respecting your patient's dignity and privacy. You literally only expose what is strictly necessary. Let's zoom in on the female-specific insertion technique. When you're cleansing the meatus with antiseptic, you absolutely must wipe from front to back. Always move from the least contaminated area to the most contaminated area. That's just basic medical asepsis principles at work. And here is a fantastic physiological trick. Ask the client to take a slow, deep breath and gently insert the catheter precisely as they exhale. Why? Because exhaling naturally relaxes that urethral sphincter, making the whole insertion significantly smoother and way more comfortable for them. Once you finally see that urine flow, just advance another couple of inches to ensure you're fully seated in the bladder, and then you can safely inflate the balloon.
Okay, for male patients, the cleansing method shifts a bit. You'll hold the penis shaft below the glands and cleanse the meatus in a circular motion, starting right at the center and moving outward. As you begin to insert, you need to hold the penis upward. The rationale here is absolutely critical. You have to use a gradual, completely unforced insertion. The sheer length of the male urethra makes it super vulnerable. If you make sudden movements or try to force it against resistance, you can cause severe, lasting injury to the urethral tract. Once the bladder is empty, you gently lower the penis, secure the catheter, and inflate your anchor balloon.
Okay, the catheter is in, but hey, our job is definitely not done yet. Once it's inserted, the basic physics of our drainage system take over and become paramount. You absolutely must hang that drainage bag below the level of the bladder. Why? To maintain gravity flow and stop any of that stagnant urine from flowing backward and causing a massive contamination issue. Also, secure it to the bed frame. Never, ever clip it to the side rails. Moving side rails up and down can suddenly yank the catheter, leading to highly traumatic accidental dislodgement. Almost at the finish line, Section 5, Safe Catheter Removal. So the procedure isn't truly over just because the urine is flowing. It is over when the patient safely transitions back to their own natural function. Just like with insertion, we start by explaining everything to alleviate any anxiety. Perform your hand hygiene, don clean gloves, and definitely use a waterproof pad to protect the bedding and preserve your patient's dignity. But listen, step 4 is where the real danger lies. Removing the catheter safely relies entirely on attaching a syringe and slowly, completely deflating that internal balloon. If you try to pull a catheter out with even a partially inflated balloon, the resulting urethral trauma is absolutely devastating. You literally must withdraw every drop of that sterile water. Then, as they take some deep, relaxing breaths, you just gently withdraw the tube. But wait, you can't just toss it in the trash right away. You must stop and visually inspect the removed catheter. You are checking to guarantee it is perfectly intact, making absolutely sure no tiny balloon fragments have broken off and been left behind in the bladder, because that will definitely cause huge complications down the line. Finally, document the whole procedure and keep a really close eye on the patient to make sure their urinary retention doesn't bounce right back and that they aren't showing signs of an infection.
Let's wrap up with this thought. While catheterization is an incredibly powerful, often life-saving clinical tool, our primary objective is always to resolve the underlying issue. Bypassing the body's natural defenses is just a temporary bridge. It is not a permanent destination. Every single meticulous, sterile step we've discussed today serves one greater purpose: protecting the patient from harm so we can safely restore their natural physiological independence. So I'll leave you with this final question to ponder. In your daily practice, are you treating catheterization as just another routine checkbox task, or are you approaching it with the profound respect that the human body's incredibly fragile internal defenses truly demand? Keep learning, stay hyper-focused, and I'll catch you in the next explainer.